Good afternoon, everyone. Welcome to the Research Grand Rounds hosted by the PPHS office. My name is Stacy Chan, and I'm the Assistant Director of Operations at the PPHS. And we are so excited to finally have this Grand Rounds about confidentiality of HIV information in research. And we have Dr. Glenn Martin here, who is the Associate Director of the PPHS office. And we have Marina Lowy here, who is the Senior Legal Counsel at Mount Sinai. And they're going to be doing a little dance today, talking about the HIV information. Just one quick announcement that if everyone hasn't heard about it, that we have something called the Clinical Research Forum. That's the first Wednesday of every month. And so the next one is on Wednesday, May 7th from 12 to 1, and we encourage all of you to attend. There's an agenda that goes out ahead of time so you can see what topics are going to be presented at the next meeting. And it's just a great opportunity for everyone to come together and hear topics that are really pertinent to the things that everyone is doing. So I'm going to give it away to Dr. Martin.
Thank you, Stacy, and welcome everybody. So it's a bit of a misnomer because and we're not talking about all of HIV in research. What Marie and I are going to focus on is areas of consent and waivers of informed consent and how that impacts generally with retrospective chart reviews in particular, charts being a euphemism now for any form of, since people don't usually put things in paper, and possibly in recruitment where people want to do runs to get, identifiable information to get people into studies. So what we'll do is I'm going to give some of a general overview of where we are, and then Marina hopefully will back me up by explaining legally why we are where we are. And ironically, the reason that this was postponed was while we were preparing for it, we had an idea that we thought might be able to loosen up some of the restrictions that we have. And in fact, Marina went so far as to consult with counsel at Greater New York Hospital Association, and most importantly with the DOH counsel who's responsible for this law. And he basically confirmed that while it was an intriguing idea, it wasn't going to fly. So we are left basically with no change from where we have been for the last 20 plus years, and which we have been enforcing at the IRB with a certain degree of rigor for the last, I'd say, decade or so, about the last decade. And if we haven't enforced it, it's because we screwed up, not because something had changed. So basically, the important points is that what we are dealing with is the HIV law as it sits in New York State. That for those of you who are old enough to remember, this law was passed originally in the 80s. I don't remember the exact date, 88. So it is about 25 years old, thank you. And it had to do with basically HIV testing and the results of those tests and how that was going to be handled, as well as confidentiality. And if you may recall back then or no, that was a very significant concern for people who thought they had HIV or were exposed to it. The degree of stigma and flat out, not just stigma, but the flat out prejudice and the like that was being shown to people who were HIV positive was extraordinary. And the concerns around confidentiality and privacy were very, very acute. Now we tend to think perhaps on good days that HIV is another really annoying sexually transmitted disease that's potentially lethal but is also rather treatable, has public health implications and the like, and it's something you should awfully try to avoid, but the amount of stigma attached and the like is nowhere near as it was when the law was passed. The problem is the law was passed and has never been modified. There have been minor modifications. That's not completely true, some of it having to do with the ability to modify the degree of consenting that goes on in clinical settings and the type of counseling that goes on, so it allows for point-of-care testing in emergency rooms, for example. But the bulk of the law has not changed. The other important thing to realize is that it just doesn't happen to be whether or not you're HIV positive or HIV negative, which of course is, but it also has to do with whether or not you were even tested or refused to get a test. So Marina will give you the more technical legal language that's used, but basically it has everything to do around HIV testing. is covered by this law and considered to be equally protected. And that, yes, there is HIPAA and various other privacy laws, but as you may recall, HIPAA is a floor, not a ceiling, and it does not preempt state laws. That state laws preempt the feds in this particular case if they are more restrictive. So the more restrictive New York state law has precedence over whatever you may think would be allowed under HIPAA. And basically what this comes down to is, under New York state law, there is basically no waiver of informed consent that the IRB can issue. So we are left with a situation that the only people who can look at HIV information are people who are allowed to look at HIV information. Marina will explain in detail who that is, but basically in this context, it essentially comes down to clinicians who are treating patients, or patients who have given, or research subjects who have given consent. Other than that, you don't have the right to go look at it. We can't give you that ability to do it. Now, we can do that for virtually anything else. I mean, the IRB, if it wishes to, and you meet the criteria, can give you a waiver of informed consent and can give you a waiver of HIPAA authorization that would allow you to rifle through my medical record and pull out whatever tidbits of information are the minimal necessary for you to achieve the scientific goals of your study, which we have duly looked at and approved. And you don't have to be treating me, you don't have to know me from Adam. But if you were looking at my chart with Glenn Martin's name on it, and you needed to know my HIV status and you recorded it, there is no way you could do that if you did not otherwise have the right to look at my record. Generally speaking, that's for clinical purposes. There are a few minor exceptions. There are a few exceptions. Marina will discuss them in a little bit. Some of them have some bearing on what we'll talk about. There's a little good news, which is incidental exposure to information that the investigator doesn't record, we don't care about. And if you think about it, every woman who gives birth in the state of New York basically has an HIV test offered to them, and I think probably has to do it. I don't recall if it's mandated or not, but it's certainly the proper practice, as well as the newborns. So you assume if you're female and have given birth in New York, there's HIV information somewhere in there, just like there is more and more in a lot of our charts. And it is possible while you are rifling through the chart with our approval, you may run into that. But as long as you don't, copy it, record it, use it, that's considered incidental, it's okay. It's a no harm, no foul situation. So that actually, with the advent of electronic records and databases and the like, that becomes a little easier to control, actually. But for the time being, if you should happen to bump into it, as long as you sort of close your eyes and don't remember it, you're fine. And certainly if you don't record it, it's good. So I'm going to just point out there are ways that we can help you do the studies, but with the very strong provision in the law that basically says you can't do them if you can't, if you actually need the waiver for yourself personally to do it, you're going to run into trouble. But there are some strategies that, through the use of computers and data warehouses, by co-opting, co-investigators you've already co-opted, but you may have to co-opt colleagues to be nice to you and provide you with information in a way that you can't identify them, or you can actually consent patients, which I know is a radical idea sometimes, but would allow you to actually do the study. But there are going to be some limitations that we'll talk about. So I will shift over to Marina Lowy's presentation, which I presume is this one. Mm-hmm. And Marina can give you more details about the actual law and not my a high-level summary of it. And then I'll come back and then we can have an open discussion.
Hi. I'm one of the lawyers here in the legal department. And to Glenn's point, at the beginning of his talk, I was telling a friend of mine, I had a guest from out of town who came by last night, and I said, I was going to look over my slides for this presentation tomorrow, and instead I didn't because she came for a visit. And she said, what's it about? And I told her, and I said, there's this really strict law in New York. She's a lawyer too, and we were talking about the law, and I said, it's really HIV and AIDS, it's just not the stigma that it used to have. And she said, hello, you live in New York City. It's not the same all over. And she's right. And maybe that explains still why this lies on the books. Although when we spoke to the attorney at the Department of Health, he had suggested that the Department of Health is looking to loosen some of the requirements around testing for HIV and AIDS, because at least his personal view was that there is so much less of a stigma nowadays. It's just an illness like any other illness. But I don't know how much success he'll have with that. So the law is very detailed, and it really regulates the before, during, and after of testing and acquiring information related to HIV and AIDS and disseminating it. And it has, the law has these 3 goals that are here. It really, and there have been some changes in the law in recent years, really geared at encouraging people to learn voluntarily about their HIV status. Now, the hospital has to offer HIV testing to every person who's admitted here, and at least once in their relationship with the hospital. And I believe, as I recall, also private physicians have to do that. So there's been this big push to try to get people to get tested and learn their status and address it. The law, implementing the law, I know one of the stated goals of the law and implementation was to change people's behaviors. I suppose if you get tested, I'm not sure if this law achieves that, but I can imagine ways in which it would. And also to bring people more awareness so that there is less of a stigma and less discrimination. As Glenn mentioned, there are really 2 components to the law. It deals with issues around testing, and it deals with issues around confidentiality. And the law, just so to be clear, it's called HIV and AIDS-related information. So it's not just HIV-related. I'm sure that was the logical flow from, I know you kept calling it HIV, but it is technically HIV and AIDS. And generally, you can't test someone without their written consent, with some exceptions. And if you're doing a rapid HIV test, then you can get oral consent and not written consent. But otherwise, really in most instances, except some exceptions, consent is required. For example, if someone's dead and you're trying to ascertain the cause of death, you can test that person without consent. Same, I don't know if you guys deal with that, but in the research context, if you can do testing and the subject's identity won't be known, and I don't know if we have studies like that here, but in theory, the law does have that specific exception in the research context. And then the confidentiality provisions are very, very detailed. And for our purposes, they prohibit healthcare providers from disclosing any HIV-related information. And the law defines HIV-related information as discussed in the next slide, whether a person was even tested, separate from the results of the test, whether the person has an HIV infection or related illnesses or AIDS, any information that could reasonably identify someone as having these conditions, including their contacts. This chart that I put up, and I don't know if the slides get posted or not, but this gives a general overview of the law. It's I found this in part of training materials online, and it to some extent it oversimplifies the law a little bit, but it gives you some sense of the level of detail that the statute goes into in terms of exceptions to the confidentiality rule. So you can see the number 1 box there talks about getting proper consent, and the law is very specific about the elements of consent, and you have to tick each one, and if you miss one, you're in violation. Healthcare providers and facilities, and what that it really intends to cover is situations where you're testing for or HIV status is relevant, for example, for purposes of a transplant, to provide care to the patient. The next box, internal communications, is QA committees and various hospital committees and such, where there's need to know. And again, the law kind of breaks down into detail what the limitations are. But I guess what I'm trying to convey to you is that there are really strong restrictions even on your internal communication of this information. So there's not kind of the broader permission that there may be for other types of health information. There's even limitations in the law. There's a whole process that you have to go through as a healthcare provider, even before you share that information with someone who's authorized to make healthcare decisions for the patient. So you can imagine that when it comes to research, it's even stricter than that. Specifically, and this is to sort of flesh out the point, I think, in Glenn's last slide, it was the last slide. Information can only be disclosed to an agent or employee of the healthcare provider under certain circumstances. So if you're a physician and you want to have a medical student or a resident or a nurse or someone, go through the record and pull out information, they have to meet these 3 requirements. They have to be permitted to access medical records. They have to be, the physician themselves have to be authorized to get the HIV-related information. And as the statute says, the agent employee, meaning the person who's designated to go through the record, provides health care to the patient, or maintains or processes medical records for billing or reimbursement. So that really makes clear that you can't just pick someone and say, oh, could you, for efficiency's sake, go through the records. It has to be someone who already has access and permission, not access, but has authority to look at that medical record. The statute is very specific that you cannot, it doesn't leave room for creativity, really. It says you can only disclose the information as provided in the law. So unless we and the Department of Health agree on our interpretation, we can't really step outside that box that the statute sets out. And there are penalties that are laid out in the statute as well. There are $5,000 fines per unauthorized disclosures, and in certain circumstances, disclosure can be a misdemeanor offense. So those 2 are incentives to comply, and then there are also punitive damages, which can be levied if there's a litigation, basically to punish. Punitive damages are basically to punish for bad behavior, so that can be in the tens of thousands of dollars. So lawyers tend to always end on a bad note, so I'll end my talk here.
So let me go back to those last 2 slides. So as I said, nothing has changed over the years, particularly, unfortunately, that would affect the ability to do this from research. What has changed is, at least at Sinai, there are certain things that have made life easier. From a computer perspective, I mean, we do have the data warehouse, and the data warehouse does have the HIV information in it. And to the extent that we give permission as the IRB, the data warehouse can give you that information as long as you as the researcher don't get the identities associated with it. So if you need a list of, 1,000 people with whatever it is that you need, and as long as it comes to you in an anonymous way, and technically it can be linked because the data warehouse knows not to ever relink it without our permission. So they could still have a code if there's some utility to that. The data warehouse can give you information. We have tried to be flexible when it comes to linking that information, because the data warehouse, as much as it would be nice if no human was involved, computers frequently need human supervision to make sure that they work, or to sometimes make junctions to make sure that one database is talking to the other database correctly. So within the operational confines of the data warehouse and the data analysts working there, we generally will give you some slack in doing it. Eventually, though, it means behind the scenes, if they have to link something up to a pathology slide or something so you can get the slide with the information, and they may actually need a name for a second to do that because it just isn't linked properly in the back, we will not make a fuss over that, because you as the end investigator may end up getting 50 slides or wax boxes or whatever with what you need in there with a whole bunch of clinical information. You still don't know who they're from. So we can be somewhat liberal there. But as Marina said, there's not a huge amount of flexibility in this. From the friendly co-investigator or colleague's point of view, now again, if you are working in the HIV clinic and you are treating hundreds or thousands of patients, and you don't mind doing this because you're the researcher, so obviously, you've got an incentive to do it. You can look at the information for research if we give you permission, no differently than the other information, because you already were given permission to look at it for clinical purposes. But if your colleague doesn't work with you in the clinic, your colleague doesn't have the right to see that identifiable information. So if Dr. A in the clinic doesn't mind doing the work to basically anonymize, and I don't mean it in a HIPAA point of view, I'm talking from a more common sense point of view. If it's not identifiable to your colleague, that's fine. So you can prepare the data set for your colleague and your colleague can look at it. The reason I don't want to use the word de-identified is like a really technical term because it also involves zip codes, it involves dates of service, it involves all sorts of nonsense that from a identifiable point of view in terms of readily identifiable or anonymous, we wouldn't care about. So if you actually needed to know the month of treatment, that it was, March of 2010 had some importance, technically that's not de-identified under HIPAA, but if that's the only quote identifier you are giving to your colleague, as your colleague cannot go back and figure out who it is, then that's fine. So we're not inflicting the HIPAA standard on you there, but more of an anonymous, not readily identifiable standard. And again, sometimes we actually have known colleagues who are nice enough to do this, who aren't even co-investigators and are only going to get maybe a little note in the bottom of the paper thanking them for the work that they did, but no more than that. But again, the key point is that they work with the patients. Now, we have been flexible when we're dealing with a clinic situation where it is a practice that is taking care of people with HIV and they're cross-covering for each other. So if there are 3 people working there and at any given time, somebody might be out on vacation or they may be out sick or whatever, and somebody's going to cover for them, and basically it is really set up as a common practice model. We will not insist that you absolutely positively have to prove that you had seen that chart at some point, during the care, but that in fact, in the general business that you were running, that you really did have access for the chart for clinical care and you were doing that. So we have not imposed very strict things there. In a minute, I'll show you the exception that we will not go beyond. But if you set that up, that is generally considered okay. The other point that I haven't written here because I'm a little loath to do it, but it is true, is that, as Marina pointed out, there are healthcare operations that are allowed for somebody to look at the chart who doesn't have clinical access without specific consent, billing being one of them, and the other being quality assurance activities. So there are occasionally times where a researcher has been able to demonstrate to our satisfaction that the person in the office would have access to this information as part of their regular duties. And they can therefore be allowed to provide, again, this extracted information to the researcher who normally wouldn't be allowed to do that. But this has got to be real. This is not that every once in a while they put together, reports of patients who are coming in for the last few days and then they're going to do a 10-year retrospective thing. If they're actually the quality assurance person who's been doing quality assurance for quite some time and they've been running reports and they've been looking at HIV information as part of that reporting, and that is what they do, then it is likely to be approvable. So that is a path that is sometimes used, but one that we hold to a really high degree of inspection, shall we say. And then lastly, you're always free to consent patients. They're always free to give permission if they so choose. And then, but what Marina was saying, and this is where we do run into trouble and where we generally get yelled at the loudest, is I have a medical student or a volunteer or a nice person who's working in my office this summer, and I want to let him extract it. And the answer is that's all very well and good, but him isn't a healthcare provider who have seen any of these patients, maybe 5 or 6 of them with you while you were doing training or something in your office, but these people don't have access to the entire medical record room because they've been treating them or they're covering at night, etc. We would not consider that an appropriate thing. So research volunteers and medical students don't work. And frankly, house officers, fellows, and the like, we are usually very inquisitive. If you have a fellow who is coming in and is rotating through for whatever period of time, we would, and again, you're going to use this group practice argument, and we buy it. We may buy it, but we're going to buy it only for the period of time that they're there. So we're not going to say, okay, fine. So the patients who are actively being seen in your practice for the last year, if their fellow was there, that would kind of make sense if they were cross-covering and the like. But it wouldn't make sense to allow them to go back and look at patients who you haven't seen in years because they haven't been in the practice and there's no way they could have seen them. So what I'm trying to say is we will give a little, we can be flexible to a limited extent, and we try to be where we can, but we can't cross lines beyond that. And that's sort of where we're at. So, I mean, in summary, that's basically where we're at. Nothing has changed. If there's anyone in the room who believes that we have let them do something that we shouldn't have, you can either let us know, so we'll internally QA it and try to correct it, or you can leave here thanking your lucky stars and hope that no one ever finds out. I leave that up to you. And for those who are more active in this, and especially if you're in the community that was most affected by this and were most effective in lobbying to begin with, the train up to Albany is about $41 one way. I urge you to jump on them. The legislature is usually there from Monday to Wednesday when they're in session. People do not normally work Thursday and Friday up in Albany. And they will be happy to chat with you about this. And quite honestly, for those who may actually have ties to the community, it would be nice if the community involved in this also sort of opened their mouths and explained why this would not be a bad thing to loosen up a little bit, since the research is generally to help people in this regard. The Medical Society of the State of New York has has been an issue for them for years, and is one of the reasons there's been finally this loosening that Marina was talking about oral consent and point-of-care testing in the ED, and the idea being that you don't have to do the full written consent because you're going to give the result back while they're sitting right there. You don't have to worry about people running away and what the risks are that you're going to have. Their behavior isn't going to modify in the 20 minutes or so that you need to get the test back. So they were actually allowed to have some more, slack in there. So there has been some loosening and there has been some movement. But in this particular area, as much as Mr. Carmel, the lawyer up at DOH, shared this view that many of us in this room have, is this is not really productive anymore, even though it should be, kept to appropriately high standards of confidentiality and privacy, that it might be nice if they loosened it up. As of now, it isn't loosened up, and I'm unaware of any legislation that's actively being pursued this session, but it is something to think about. So unless Marina has anything to add at this time, that's basically it, but we are more than happy to answer whatever questions you may have, or whatever strategies you may have thought of that we have not been smart enough to think of, or if you'd like to see if you can, come up with something that we like, that'd be great. Viv?
Yeah, so I was wondering whether you could comment on how an investigator would operationalize the following situation on an industry protocol, something like an inclusion criteria of known HIV disease.
Generally, if it is in the consent that you...
No, that's the entry criteria for the protocol.
Yeah, well, as you know, we're not a big fan of allowing people to look at information for entry criteria without patients' permission and consent, unless you're treating them yourself and you already know them because they're your patient. So if it's your patient and you came to me, hey, Glenn, do you know any HIV-positive depressed patients over the age of 35 who aren't currently drug abusing and live in Queens? I'd go, yeah, I might. Why? And that because I'm not doing anything that I don't already know, and I may say I'll be happy to approach them and see if they're interested in contacting you. But there's no obvious way around that, because you shouldn't be rifling through records as to determine whether or not they're eligible without people's consent.
So the offshoot to that is that would always necessitate a consent for testing. That was always my interpretation of inclusion-exclusion criteria.
Yeah, it would have to.
Though in oncology, people have really argued against that.
But lots of people argue against a lot of things, so I will accept that statement as fact. But I don't know if they need the full consent for testing if you're not testing them. If it's already been tested and it's in there, then simply within the research consent form, if it's clear that in the HIPAA section of, it says what information that we're obtaining, either in the HIPAA section or in the description, it says we will be looking at HIV results, and the HIV box, as we call it, is in the authorization, which basically says you can call the Human Rights Commission or whatever it is, you're okay. So you can do that. The flexibility that we do have sometimes, as you know, and it's a little bit of a game, but if somebody calls up, and we've done this about sort of, screening scripts, is that if you were to, and we hopefully will have some actual updated guidance available on our website, within the next, let's say, 4 weeks or so. But what we've sort of said is that if you say, look, to be in this study, you can't be left-handed, you can't be HIV positive, you can't be actively abusing drugs, you can't have a legal record, whatever it is, and you have to have this and this. Does this sound like it's worth you coming down and talking to me, or is it going to be a waste of your time? That's okay, because you're not asking specific information. If you're specifically asking HIV positive, then we have an issue, because you just can't do that. Yep.
So if you're, a clinician and an investigator, you're seeing patients who have HIV, and you think that they're good candidates for a study, but of course, there's, we often do like a pre-screening, and so you ask the patient, can we, send your chart, can our coordinator take a look at your chart to see if you qualify for this study, and they'll reach out to you. Do you need written consent or their consent to send that information for that pre-screening by coordinator?
And it's HIV in particular is in there.
Co-infected patient, yeah.
Right.
Yes.
I suspect that we would want consent of some shape, manner, or form. And normally we don't approve things that are exactly like that, where we will say, do you mind if we will generally say, if you think that you have somebody, clearly what we often approve is, if you have a patient who you think is eligible for a study, then you can have them talk with the coordinator. But that's different than having the coordinator look through the chart. So if the coordinator is talking with the patient, you're right, and they go through the same thing. They shouldn't go through a detailed checklist asking what they have. It's more the other way, which is, these are the inclusion criteria, here are the exclusion criteria. Does it make sense for us to continue? And yes, I understand to some extent it's a bit of a fiction, because somebody might say, oh, no, I can't, I'm HIV positive, or no, I can't, I've done this.
Specifically for HIV.
Right. Well, yeah, and then, I know there's a certain degree where it's pretty obvious at that point. But again, if they're your patient and you're saying, look, there's a study about HIV and hepatitis C in heterosexual males, and all three of those are potentially dangerous assumptions to make, and you go to one of your patients and say, I think you might qualify, are you interested in the study? I think we'd not make a particularly big deal about that. Because also, there may be controls, there may be this, there may be reasons to think that it's not exactly outed to the full extent that you may think. But no, we don't normally let research coordinators look at charts without consent anyway, so that shouldn't be there. And we wouldn't want them to ask a specific question, but we know that there are times that by simply saying, you might qualify, do you mind if they talk to you, then obviously it means that you think that they probably, qualify.
Well, that's still getting their consent.
Yeah, you've at least asked them. Yeah.
Because
Yeah.
we're gonna have to give their name, by giving their
Right.
name to the coordinator, you're disclosing the confidential information.
Correct.
If you were really a technical lawyer, you might want to write.
Well, we normally ask that the researcher certainly make a notation in the chart that said that they spoke with the patient and they agreed to be referred. We don't enforce that, but we have always promoted that as good practice. In Epic Land, that will become, I believe, even easier, because we've worked in Epic Land that they'll send out I don't know, they're using BPAs or whatever they're using, that will say, hey, this patient looks like something that Dr. Martin is trying to find. Could you ask the patient whether or not he wouldn't mind talking to Dr. Martin or his rep? And then you either click a box yes or no, and that's basically saying the patient's agreed to it, I get the name, and then I can go find the patient or whatever. So some of this is getting more automated anyway as it goes on, and at the same time allowing people to document that, the patient agreed. So I think that's what we worked in actually to the language when I spoke to Canry about building it. I think we did that right, just to take care of that. So yeah, it may not be the full 20-page consent that people are worried about, but yeah, you should ask permission. But again, they shouldn't be looking at charts directly. Anyone else? Anyone have a good idea that they thought they wanted to float? Anything that's not ambiguous that I'm deliberately trying to leave a little bit ambiguous? Psychiatrists are more comfortable in ambiguity than lawyers are, so. Yes?
That's why we're such a good, if you have a study that is co-infection, HIV and Hep C, you already know the patient is HIV positive, and the study is asking you to test them for their viral load, not to verify that they're HIV positive, just to see what their viral load is, because that's an inclusion and exclusion criteria. Do they have to sign a separate HIV consent?
All right, yeah, that's right. So the question is, as I understood it, is as part of a situation where we presume you've consented the patient into the study, you're now going to do one of the tests. One of the tests is somewhat sneakily, they're not going to do, quote, an HIV test, but they're going to look actually for the virus in a viral load situation or something else where they have to consider that full HIV testing and file the HIV consent. My hunch is yes, only because I can't imagine how a viral load would not be considered information pertaining to the condition of either HIV or AIDS. So I would say yes. Well, you run into that problem that if you're doing the HIV testing, you have all that counseling, Michigas, that you have to go through with it, and that's basically what the consent says. It explains, and frankly, the consent reminds everyone that if you don't have to be tested here, you can go to DOH and you can get it tested totally anonymously, and that whole thing that they still have in place, where they can tell you if you're HIV positive without you having to reveal your identity using numbers and the like, that still exists. So that if you're doing HIV testing, for sure, we tell you to use the HIV thing. I suspect we would tell you to do that. It's an interesting question. I know. I understand what you're saying. I realize, and you're not adding anything.
It's usually to see what they need to be undetectable to enter into the study.
Right, that they're stable enough. So let's see what have you.
Say, so the statute defines, oh,
Yeah, good point.
Lost my spot here. So the statute defines HIV-related test or HIV-related testing to mean any laboratory tests, or series of tests approved for the diagnosis of HIV. So,
Fine.
so I don't know if this,
Yeah.
so
Yeah,
give-
so that sounds fine.
How do you interpret it?
Yeah, no, I would think, and I don't think we've actually insisted that people have done it, and I think now we feel even more comfortable in not insisting that you do it. It would be in the consent, as it always has been, that you're going to do. I would say that is something we'd expect to see in the consent, but I'm glad that we would not have to impose what would be obviously silly if they know they're on HIV.
Is that a test generally approved for diagnosis of
What, the
HIV?
viral load?
Yeah,
You'd do it
is
after
that
they
what
had
you-
HIV, yes. Yeah. First, you make sure, yeah, the
Clinically
antibody test
naive
would be the first
question.
step, and then you would start doing the HIV load and the like, or to monitor treatment
So that
response.
you wouldn't normally do it for diagnosis?
No, I don't think you would jump
So
to
you're
that
good to go.
normally. That would be an odd way of doing things,
Okay.
to be truthful. I mean, some of this gets silly, as we know. I mean, this is a little bit, because we have this problem in the health information exchange arena, where you're exchanging people's problem lists, and you go, oh my God, we can't let you know they're HIV positive without their specific consent, but we'll be happy to share with you that they're on 3 retrovirals. And antiretrovirals, it's sort of like, oh, I wonder what that's for. Right, so you get into some of these things where, but New York State, again, this is what happens when you write laws 30 years ago and don't update them. It's like the genetic law, where they talk about genetic products and this and that, and then we get to scratch our head and going, that mitochondrial DNA also? What about RNA? What about this? Is this genetic? Is it not? What did the legislature think? Which arguably is already a higher standard than you would normally hold them to. So I'm not, it gets a little unclear at times. But generally, our standard would be, you would expect patients to know what's going on in the study. So if you're going to be doing that, we'd expect them to know that. But to have them sign the separate consent. The separate consent we absolutely will do if you're doing an actual flat-out HIV diagnostic test, which occasionally happens also. Because that'll often be an exclusion criteria where they want to know, are they HIV positive, and you'll do it that way. I mean, not the raw load where you know they're positive, so you're going to do it. So thank you for asking that question, actually. That I did not mean to be ambiguous. Anything else that you can stump us with? Thomas, anything? I'm usually relatively, like I said, I'm relatively immune to embarrassment. Yes, Miss Magic. A plant.
What happens with if you had received data, and that data included HIV?
Oh, dead people.
And if that's accessible for research?
No, I believe dead people. So the question was, once you're dead, do you lose your privacy rights? You never lose your privacy rights under HIPAA when you're dead. Unless I think you're dead 50 years, I think the historians finally got that changed. So we can figure out why FDR died and why JFK died. Actually, I knew that without a HIPAA release. But there are things that finally got changed in terms of the 50-year. But I think I'm pretty sure your HIV information is still considered private, and you would probably need consent from the executor at that point or whoever. And that's a real nuisance, who actually owns your medical record rights after you die. And that's an easy answer where we say call Marina. No, because actually trying to figure out who owns medical record rights after somebody dies is not necessarily the executor and the like. It can get really complex. And all I know is that it's complex enough to know that I don't opine about that. That's a quick call to me. But yeah, I'd say the take home is dead people have protections in this regard, identifiably. As much as it'd be interesting to know for research and other gossipy reasons. Perhaps. Anything else? So if not, thank you all very much for coming. Hopefully you found it useful, or at least, as I said, it's unfortunate. We hope that we would be able to say that we'd loosen things up or not, but all our inquiries have just reinforced the fact that we've actually gotten it right. And hopefully it'll change. But until then, we will work with you and be flexible when we can. And there's only a little bit of wiggle room, but where there is wiggle room, we will try to help you find it. And if not, as I said, you can shoot the messenger if you want, but a train ride to Albany would probably be more effective in the long run. So thank you very much.